Okay, we're going to get started with Grand Rounds because we have lots of speakers today, and because Dr. Gill has been nice enough to join us, and she's got a sick daughter that she needs to go to attend to right away.
Okay. Can everyone hear me? Thank you so much, and thank you for the invitation. I'm just going to, I was asked to give a 15-minute overview of a topic that I think as emergency physicians you're going to see a lot more of. And I apologize, I'll tell you right now, this is a bit focused to endocrine, because I'm an endocrinologist here at St. Paul's. But it's probably I hate to make my especially a bit more complicated than others, but it is probably the more complicated one to identify, and hopefully over the next couple of months you'll have other specialists talk about their own complications related to these drugs. Those are my disclosures. And so my hope is in the next 15 minutes or so just to give you an idea of what these drugs can do, and when you see these sort of complications, when you see these patients, just to think, well, maybe we should do these appropriate tests. Just to give you an overview, do I still have a pointer? No.
It'll be on the laptop.
Oh, can you see? Yeah, okay, perfect. So when you think about our immune system, right, we've got our T-cell activation, and we've got a number of mechanisms that stimulate our T-cells, and we've also got our own, bless you, we've also got a couple of regulators within our immune system. Bless you. Are you okay? Okay. So it's just like a knee reflex. So you've got your antigen-presenting cells. You know, they've got their major histocompatibility complex that keeps going that way, that binds to our T-cell receptors and therefore will stimulate a T-cell response, right? You also have these proteins, here it's labeled B7, right here, that also bind to these receptors called CD28 receptors, and they have an inhibitory effect. So these also stimulate the T cells, but you also have these receptors called CTLA4 that these B cell ligands from these antigen-presenting cells that also bind, and they have an inhibitory effect. So you've got this two sort of processes that stimulate your T cell activation and one that counter-regulates it. So that's how, you know, we regulate, different antigen-presenting cells, and it sort of gives us a controlled T cell response. We also, of course, have something called programmed death. So when you've got these antigen-presenting cells, they can also bind to these programmed cell death receptors. So all antigen-presenting cells can then also inhibit this response by stimulating this PD-1 pathway and inhibit T-cell activation. So what normally tumor cells, we're finding that tumor cells have a way to inhibit this programmed cell death process. They can present as antigen-presenting cells, and this is why, you know, the immune system does not pick up these technically foreign cells. These immune checkpoint inhibitors, what they do is they basically suppress this whole regulatory process. So you have drugs that basically inhibit this CTLA4 receptor process, so it inhibits that inhibitory pathway. So you've got then just an excited T-cell, upregulated T-cell activation through this process. And with the tumor cells, as I said, can mimic antigen-presenting cells using these programmed cell ligands, and they basically have their drugs that inhibit that process, so therefore you have no programmed cell death. So at the end, the process is with these drugs, you have an enhanced T-cell response and focused against these tumor cells, and therefore these have been very successful in anti-neoplastic therapy. And they're basically was initially treated with melanoma, but just every couple of months we'll see New England Journal articles of how these drugs are actually being quite effective in a number of malignancies. maybe just get rid of the health. So anyway, with these immune celled, with these enhanced T cell activation, of course, you're going to see, therefore, increased immune response. And so the complications that we are seeing now with these drugs is increased autoimmune disease at quite a significant level. So both in people who are predisposed and those who are not. And technically, it can affect any system, head to toe. So it can have neurological symptoms, various neuropathies, autoimmune neuropathies, autoimmune myopathies, so joint problems, so rheumatology is involved, various skin autoimmune dermatological abnormalities, pneumonitis, myocarditis, nephritis, you name the organ system, you will see it. So this is why it's now they're using various multiple disciplines to intervene. And most of these treatments are steroids. So, I think for emergency physicians, you just need to know these patients are told to tell, whenever they come to the hospital, to tell the physician that they are on these drugs. So you need to just think in the back of your mind, this could be something autoimmune, depending on what their symptoms are. Probably contact the oncologist and then contact the appropriate specialist because these patients will relatively quickly need high-dose immune therapy. Endocrine's a little bit different because we don't often need to use steroids, and these are usually treatable. The diagnosis gets to be a bit of the challenge, though, because as you all remember, steroids will suppress your whole endocrine status, so it becomes difficult to interpret various test results. But we have had reports of thyroiditis and pituitary disease are the most common, but there have been reports of type 1 diabetes now, or I should say autoimmune diabetes, reports of hypocalcemia due to hypoparathyroidism, so they'll come in with tetany as examples. And this can happen within receiving the first dose up to 2 years after their last dose. So once the immune system is stimulated, you can see these complications even after these drugs are discontinued. With regards to the severity, the oncologists know there's a severity as far as depending on how severe the symptoms are. Sometimes patients can present relatively mild, and it's biochemical, to life-threatening. And usually up to grade 1 and 3, their chemotherapy or their immunotherapy has to be stopped. After 4 or 5, usually, it can be continued, but when it's grade 3, 4, 5, higher dose, higher severity of illness, usually their immunotherapy has to be stopped. And there have been, unfortunately, reported cases of fatalities because of these complications. The other thing is, as I mentioned, there are multiple different types of checkpoints and receptors that can be affected and drugs that are being developed. And we're seeing now that they're using combination therapy from a cancer perspective. So it's, you can see small prevalence of complications, say with, the ipilimumab or the PD-1 inhibitors. But when you see the last column of combination therapy, the risk of these side effects really exponentially rises. And that's what we're seeing. A lot of the oncologists are using for aggressive cancers. They're using combination treatment, which is being successful from the cancer perspective, but really then causing a huge number of side effects. So I thought I'd present a couple of cases just to run by. I apologize if I'm too fast. I'm trying to make sure I'm within my 15 minutes, just to give you a sense of what you may see when they present to the emergency department. So this was a gentleman, he had renal cell carcinoma. He was treated with multiple courses of chemotherapy and then treated with 2 courses of combined immunotherapy. And he presented to the emergency department at VGH with shortness of breath, palpitations, tremors. There was no family history, no other history of autoimmune disease, bit tachycardic, nothing else. And of course, they do now, as part of the screening, they will screen a number of things when their patients are put on these drugs, including thyroid, as thyroid is quite common. And his baseline TSH was fine, and his subsequent TSH just a couple of weeks later was good. So he was fine, but you can see that normally people's TSH doesn't drop by 50%. So we're teaching the oncologist, if you've got a TSH that's dropping, something is going to happen. So basically, it happens fast. Within the first treatment, baseline he was 3. Within the first treatment, his TSH dropped to 1.8. And now here we are 2 months later, and his TSH is suppressed with a high T3, T4 levels. And he had a scan done, which was consistent with the thyroiditis. And the interesting thing about this is, if you remember with thyroiditis, this is something that presents. They have their hyperthyroid phase for a couple of months, then they become euthyroid, and then they actually become hypothyroid for a few months, and then they normalize. With immunotherapy, we are learning that the pathophysiology is almost ramped up, and with all these disease states, the presentation and the course is very unique to what we normally see in day-to-day practice. So as you can see, within weeks, he was having TSH measurements every couple of weeks. His TSH went from being suppressed to 40. I mean, he switched. There was no transition. He switched from hyper to hypo very quickly. Symptom-wise, interesting, a lot of these patients may not be very symptomatic or still might be mildly hyperthyroid, where their TSH is 40. So the symptoms lag the presentation. But this is what we're seeing with this population. And so they can present with any cause. Both hypothyroidism or hyperthyroidism can occur. And usually it can occur within the first couple of treatments, and it can occur up to, it's been reported, even up to 2 to 3 years after stopping the treatment. And if there's a pre-existing autoimmunity, that might put them at higher risk, but we've seen people with no history of autoimmunity have this presentation. And as I mentioned, the course of thyroiditis being the most common complication, it just happens in weeks. And the other thing we're seeing is usually most patients with thyroiditis resolve, and they are euthyroid at the end. These patients stay hypothyroid. So before we used to, when this first happened, we used to watch them, but now the moment their TSH starts rising, I start them on thyroid hormone because they don't usually, it's not a self-limiting disorder in this population. So when they present, of course, if they're thyrotoxic, we would give them beta blockers. Majority of the cases are usually thyroiditis. There are a few cases, I would say about less than 5%, that are actually Graves' disease. And the problem is that it's hard to differentiate. You can get TSH receptor antibodies. So when these patients come to the emergency department, I would order anti-TPO and TSH receptor antibodies. But depending on how clinically how they clinically present, you could just basically treat them with beta blockers and then refer them to endocrine, because a lot of these patients resolve spontaneously. And we find now, because the course is so quick, if I don't see that TSH change within a couple of weeks, I will switch them to start them on antithyroid medication. If it's feasible, you could order a thyroid scan, but a lot of these patients are getting CTs like every couple of months, so they've had huge iodine loads to begin with, so sometimes that's a challenge. An ESR can sometimes be helpful for a thyroiditis, but they don't present with the common symptoms of sore throat, neck, nothing. It would just be clinical hyperthyroidism would be their only presentation. And like I said, as they proceed through this course, they'll eventually develop long-term hypothyroidism. The important thing, though, is that there have been a few cases reported now of thyroid storm. So as emergency physicians, you need to recognize that, which I'm sure you all do, and that presentation doesn't change. But if they have any acute onset of heart failure, cognitive changes, acute liver dysfunction, then you need to think of thyroid storm, consult endocrine. It's a tough diagnosis because this is a very unique population. These are sick people with malignancies and other side effects. So it's, even when I get called on this, we will come down and see them, but you don't know if this is thyroid storm or, you know, they have the pneumonitis or the cardiac failure because of the myocarditis that they have superimposed. So oftentimes I've erred on the side of caution and just treated them as a thyroid storm and in the ICU until we sort everything out. But this is just so that you're aware this can happen with these drugs. Does anyone have any questions or burning right now? Otherwise, I'll keep going. So case number 2, this is a gentleman who had metastatic melanoma, was on immunotherapy for a number of cycles, and he actually developed complications of aseptic meningitis, and the immunotherapy was stopped. But 8 months later, he presented with fatigue, myalgias, anorexia, and a weight loss, and his AM cortisol was quite low. Unfortunately, nobody ordered a ACTH at that time, and he was just noted to automatically develop, does that work? Anyway, he was automatically treated with steroids. And he didn't have any pituitary abnormalities. We had checked for that. And the problem is that a lot of the times, these patients are on high-dose steroids for other reasons, because oncologists love prescribing steroids. And so you don't know if this is low cortisol because they've been exposed to steroids, so you really have to rely on the clinical presentation. The other thing I often will request physicians is, if you see that low cortisol, before you give them any steroids, give me that ACTH, because that ACTH will tell me if this is a pituitary or an adrenal problem. So that's the big favor I would ask, is just run that, get them to, I don't know if they can add an ACTH, because I think it has to be put on ice, but just order that ACTH and then give them the steroids if in doubt, because that becomes important as far as diagnosing the cause. Primary adrenal insufficiency is quite rare, but they can develop an adrenalitis and even bilateral adrenalitis. Usually the adrenalitis part recovers, so they can have normalization of their adrenal glands, but unfortunately the hypoadrenalism persists, so these patients are usually on long-term steroid therapy. So the presentation, if you all remember, a lot of fatigue, nausea, vomiting, diarrhea, postural hypotension, there'll be hyponatremic, hyperkalemic. So the oncologists now are getting really good at recognizing these findings. And so the ACTH will tell me if it's an adrenal problem, the ACTH will be high. If it's a pituitary problem, or if they're exposed to steroids and nobody knew about it, then that would be, the ACTH would be suppressed. So that can give us some guidance as far as how we're best to treat. The other thing, of course, is that if it's an primary adrenal problem, they need both mineraloid and glucocorticoid replacement, or if it's just a primary pituitary problem, their kidneys and adrenals work from their mineralocorticoid axis, and they don't need Florinef. And so if they presented in stress doses, I would give them hydrocortisone higher doses. You could give them 50 milligrams IV as a bolus dose when they come in, and then usually 25 to 30 milligrams to up to 50 milligrams a day. And then we usually try to taper them down to a 15 milligram per day dose on average. The third case is a patient who had, again, a metastatic melanoma, was started on immunotherapy, developed complications, skin dermatitis, developed GI complications of enterocolitis within the first couple of treatments. And after the second treatment, it started developing headaches, fatigue, and muscle weakness. He didn't have any nausea, vomiting, no vision changes. And, oh, darn, all right. Well, anyway, there was an MRI, and the MRI basically they did I'm just trying to think if this comes maybe. Okay, you know what? I'll miss that. Because of the headaches, he had an MRI, and the interesting thing with the MRI is, even though it's an MRI head, you can see the inflamed and enlarged pituitary with a pituitary stalk. So he was diagnosed with hypophysitis. Based on that, his cortisol levels were lowish, but for someone coming to the emergency department, they were thought to be low. His TSH and free T4 was low, so then again, that would suggest more of a pituitary problem versus a thyroid problem. He didn't have any evidence of diabetes insipidus. They did check his testosterone, which were low. His growth hormone was low, so he was diagnosed with hypophysitis. And so accordingly, with acute hypophysitis, especially when they have headaches or vision changes, we treat them with high-dose steroids, 1 milligram per kilogram of prednisone. You always want to treat the adrenal insufficiency first, then the thyroid. So he was treated with steroids first, then he was replaced with thyroxine, and the testosterone was given afterwards. And his other hormone levels were all normal. Unfortunately, again, about 20 to 30% of these patients can resolve biochemically, but a lot of these patients need to be on long-term hormone replacement. So as I mentioned, hypophysitis can develop any time within the first couple of months, and combination therapy, there's a higher risk, and you can have panhypopituitarism, or you can have isolated. So we've seen cases of just isolated adrenal insufficiency or hypothyroidism or hypogonadism. And the thyroid and adrenal is usually the most common. Diabetes insipidus, we have seen one case that's reported with combination treatment. So the concerning, though, is if they develop with headaches, vision changes, they can have, if there's severe compression of their optic chiasm, they can have cranial nerve defects. Excuse me, they can have, they can have the hypoadrenal symptoms, so the weight loss, anorexia, nausea, vomiting, and biochemical findings, as I've talked about. They can, on imaging, have pituitary enlargement. Optic chiasm is rare, but they can sometimes have compression of the optic chiasm, which can cause vision changes. And stalk thickening, I always tell their fellows, if I can see the stalk, that means it's thickened. So their stalk is usually thickened. I'm so sorry, there was an image below, but it's not coming out. The interesting thing is that actually the neurological, the neuroimaging changes resolve. The biochemical don't. And so these patients are usually, again, treated with steroids followed by thyroid hormone treatment. If they have no symptoms, so suppose they come in, but they don't have the hypophysitis, they don't have the headache, so it can be a milder form, you don't actually have to give them the high-dose steroids. Then you can just give them replacement doses. The thought being that high-dose steroids does suppress the T-cell activity, which therefore suppresses has a risk of suppressing the benefit from the cancer therapy. So we only give the high-dose steroids if they've got the hypophysitis findings on imaging and they're presenting with headaches or vision changes. And as I mentioned, we always give the thyroid hormone replacement after steroids. Sometimes diabetes insipidus can be unmasked. So we recommend if you're starting steroids, check their thyroid. There's electrolytes afterwards. They might have DI symptoms within a couple of days afterwards. As I mentioned, there have been a few reported cases now. We've seen probably about a half a dozen cases in the lower mainland of acute autoimmune diabetes, so they present with DKA. So again, if they're on immunotherapy, the treatment of DKA is the same, and a lot of these patients then do need long-term insulin therapy. So in summary, this is a new set of patients that you will see that will present to your emergency departments. And the oncologists have informed the patients patients are all given a booklet with all the potential complications, and if they present to the emergency department, the first thing they need to do is tell their emergency physicians that they're on this drug, and the hope is that that will then, for you all, make you realize that so there could be something autoimmune, and then based on their symptoms, order the appropriate tests and notify the oncologist. Thank you. And if it's time for any quick questions.
Thanks so much, Dr. Gill. So I know you have to go, so we will keep you, but I think my only question is, other than the booklet, is there any other way for us to know if we see a patient on monoclonal antibodies, how to determine if they might be at risk for this? Well, the patient they're supposed to be wearing some sort of bracelet or have something in their wallet, like they're supposed to tell you. So I would say if you have a history of, well, I'm a cancer patient, then the first thing I would ask is what treatment are they on, and if they're on these MABs, on these immunotherapies, and you can clarify. I mean, hopefully the oncology notes should be on Care Connect, but otherwise you can call the oncologist and to know, because then that just opens up a whole new set of diagnoses that you need to consider. Great, thank you so much. All right, and I have to go. Yeah. Oh, thanks so much for coming. And we'll move on to Victor Leung, who's here. Thank you, Victor, for waiting. Thanks so much.
Okay, so I thought I'd give a 10-minute update on community-acquired pneumonia. It is one of the most common infections presenting to hospital and leading to mortality sort of worldwide. But this presentation of community-acquired pneumonia, although it may seem simple and something you see day to day, there have been some changes recently in the 2019 American Thoracic Society guidelines and the IDSA guidelines. Can you hear me okay? Okay, perfect. So I wanted to present the most common questions. In this set of guidelines, they address 16 common questions related to treatment and diagnostics in community-acquired pneumonia. So the first question is around diagnosis, and knowing that it is important to use diagnostic tests if they make a difference, and not using diagnostic tests that are not appropriate in particular settings. So I just wanted to get a sense of how you're using diagnostic tests for community-acquired pneumonia. So first question, so in adults with community-acquired pneumonia, the question is, should the following tests be done at the time of your clinical diagnosis? So for maybe show of hands, how many of you who are admitting patients to hospital or discharging patients are asking for lower respiratory tract samples or sputum samples for gram stain and culture? Just show of hands. Okay, so most of you aren't. What if you have a patient who's being admitted to hospital with more severe pneumonia, they're on oxygen, their respiratory rate is high, you've started empiric therapy? Would you order sputum cultures at that point? Okay, so we have a few hands. So in the past, the ATS guidelines had recommended that lower respiratory tract specimens weren't necessary in the majority of patients unless they were being admitted to ICU. Things have changed a bit, but not necessarily based on hard evidence that these respiratory tract samples change outcomes. So in their final recommendation for sputum cultures, along with gram stain, it is recommended that if you have a person who has severe pneumonia, where you are starting empiric therapy for MRSA or Pseudomonas, at that point, respiratory tract specimens are indicated. So I'll just come back to this at the end with a summary. What about blood cultures? So for the average person who you're admitting to CTU with the primary diagnosis of CAP, are you ordering blood cultures? Okay, so a few hands. Blood cultures are actually recommended for, again, all patients where you're going to start empiric anti-MRSA and Pseudomonas therapy. And I'll go back to the rationale for blood cultures and sputum cultures in a bit. How many of you have ordered urine Legionella and pneumococcal antigen tests? So these are non-culture-based tests. They're looking for Legionella or Streptococcus pneumonia antigen that's excreted in the urine. And these antigens can last for up to several weeks or even months and stay positive in people who have been infected with these two pathogens. So we've recently made a change in our ICU in that any patient admitted to the ICU is asked to have a Legionella and pneumococcal antigen. Since that change, we've diagnosed multiple patients with Legionella and Streptococcus pneumonia in cases where cultures have been negative. And so that's allowed us to change antimicrobial therapy. And then finally, influenza testing. So the influenza season is not yet arrived, but coming. And it is recommended that when you have a diagnosis of community-acquired pneumonia during influenza season, that you also ask for a nasopharyngeal swab. So in the end, the rationale for many of these diagnostic tests is not necessarily based on hard outcomes that it's improved mortality, but with increasing antibiotic resistance, it is important to have a better understanding of how the epidemiology of community-acquired pneumonia is changing. So in cases where you are broadening therapy to cover for more drug-resistant pathogens like Staph aureus and Pseudomonas, it is recommended at that point to do more diagnostic testing. So in summary, if you are admitting a patient with severe community-acquired pneumonia, then you should be testing for sputum cultures and blood cultures. And in anybody who you've decided anti-MRSA therapy or Pseudomonas therapy is indicated, you would also start do those two tests. And that pneumococcal and Legionella antigen should also be ordered for all cases of severe CAP and nasopharyngeal swabs during influenza season. So any questions about those common microbiologic tests for pneumonia? Yeah, Chris?
Yeah, so we do a ton of outpatient therapy for community-acquired pneumonia. You know, and I don't know, like we have restrictions on the type of swabs we can order for influenza. It actually won't allow us to order it unless you have specific secondary diseases. So I'm not sure the lab is in alignment with this. The second part is we're treating patients who have SIRS type stuff with intravenous antibiotics and bringing them back for IV until blood cultures are available. We're not necessarily doing all the other adjunctive testing or the sputum cultures and stuff. So this isn't routine practice. And I, you know, when we admit a patient, typically the internist or the family medicine service, whatever, orders the, you know, other serologies and stuff. So like Legionella will be ordered by the internist if it's an appropriate case. I think I've ordered one in 2 years. So yeah, I don't know if you want to get a protocol in place or you want to update what we're seeing when we do our orders or whatever the Cerner power thing chart stuff it tends to be, but it's a little bit different than what you're explaining here.
Sure. So I'll just clarify, for the outpatient, so someone who you feel does not need to be admitted to hospital and is presumably going home on oral antibiotics at that point? Is that the first scenario?
They may be coming back for review in 24 hours, repeat intravenous antibiotics. So we're not admitting every patient with a fever, pneumonia, and a little tachycardia. If their vitals are stable, they're improved, they have findings on x-ray, and they're otherwise healthy. We'll send them home and have them come back for reassessment in a day, and that'll happen for 3 days, and then they get either changed to oral, or if the blood cultures are positive, then they may get admitted depending on what they grow.
Is there a reason in those scenarios why, if you felt that the patient can be discharged is well enough to go home, that they can't go on oral antibiotics as opposed to continuing with IV? I'll show you the severity stratification on empiric treatment.
Yeah, one thing is we don't want to admit all these patients, and we may not be able to keep a handle on them. So the reassessment part is a big part of this, so it pulls them back in 24 hours, and they may not reliably follow up. So that's definitely one piece of it. Some of them we'll send to OPAT. I don't know if they've seen them there. It's similar to what we do with pyelonephritis on patients that we're not admitting with pylos.
Okay.
But I think to be fair, because this is a minority of our pneumonia patients.
Yeah, I agree.
Yeah. So then for the inpatient ones, on the Cerner power plan, many of these tests are available. None of them are pre-checked as a default. So with specifically for influenza testing, the 2019 guidelines now recommend that if the influenza-like illness symptoms started within the last 48 hours and the person does not need admission, it is recommended that they also start on oseltamivir with the primary purpose of decreasing symptom duration. This is a change from the 2019 guidelines, where patients who were outpatients, like patients who were generally outpatients, were not necessarily treated. Now the recommendation is that if they have influenza-like illness within the last 48 hours and they're outpatients, that they be treated. And if they are inpatients, even if it's more than 48 hours, oseltamivir is also started. So the testing restrictions will have to change as well, and they have changed on the power plan that's coming. So the question will be how often you use those power plans versus just ordering off your own order sets. Any other questions about the diagnostics? Okay, so let's go to treatment then. So in an otherwise healthy patient, meaning they don't have comorbidities but have a diagnosis of community-acquired pneumonia, this is a patient you're discharging. It's recommended that they shouldn't be started on IV antibiotics. So of the oral antibiotics, I'm just wondering what the general, the most common prescriptions you provide are. So hands for amoxicillin monotherapy. Okay, so we have a few hands for amoxicillin. Doxycycline monotherapy. Okay, so more of that, and we're actually seeing quite a bit of doxycycline use as well. And then finally, azithromycin. Okay, so seems like the majority voted for doxy and azithro. Very few of you selected amoxicillin. So I'll tell you the rationale of why amoxicillin is first-line therapy in the otherwise healthy patient. So if we recall, the most common pathogens in pneumonia is still Streptococcus pneumoniae, dominating in terms of bacterial pathogens. You also have Haemophilus influenza and Moraxella. The atypical pathogens are much rarer, but possible, and now we're seeing increasing number of viruses causing pneumonia as well, number one being RSV, rhinovirus, so on. So if we're looking at an otherwise healthy patient, the probability if they have community-acquired pneumonia is that this is all Streptococcus pneumonia. A smaller proportion will have Haemophilus influenza and or Moraxella, and amoxicillin has excellent activity against Streptococcus pneumoniae. So it's rare to have beta-lactam-resistant strep pneumo causing pneumonia, and that's why in the UK for the past 10 years amoxicillin has been the go-to agent. In North America, during the last set of guidelines in 2007, amoxicillin wasn't promoted to be monotherapy. Instead, amoxicillin clavulanic acid was used. The rationale for that was for concerns of increasing resistance in Haemophilus influenza and also Moraxella that produces a beta-lactamase. So looking at our local epidemiology from isolates in the community and at St. Paul's, amoxicillin is still the most appropriate agent to use as monotherapy in the otherwise healthy patient.
So you're not seeing much mycoplasma or?
No, so we don't test for mycoplasma, but in randomized controlled trials where amoxicillin has been used, patients who don't even get, most of the time don't get pathogen isolated, the improvements are the same whether you use the atypical coverage or not. So in the person with the low risk is ready for discharge, amoxicillin would be the first choice without need to cover atypical. Yeah, amoxiclav is not necessary.
What about second generation cephalosporins?
So cefuroxime has been an option, but is preferred in those who have more comorbidities. So in general, in a healthy patient, amoxicillin is adequate. Cefuroxime also covers Streptococcus pneumoniae, but the problem with cefuroxime is as a second generation cephalosporin, the risk of C. difficile is higher.
Victor, do you know if the Spectrum app is going to be updated with the new guidelines?
Yes, so currently our Spectrum app has amoxiclav as the first line in someone who has a low CRB score, but we'll update that as include amoxicillin as the first one without comorbidities. So doxycycline can be used, although it should be considered an alternative. So if someone has recently been treated in the community with amoxicillin in the last 3 months and you want to change the antibiotics empirically, then doxycycline could be used. Azithromycin monotherapy is no longer recommended as first line because of increasing strep pneumo resistance. And when azithromycin has been used heavily in the past, there's also been increasing resistance for other antimicrobials among Streptococcus pneumoniae. So the bottom line for healthy, otherwise a patient who's healthy and going to be discharged, amoxicillin 1 gram TID should be your first-line antibiotic. And the duration, if you are going to prescribe that, should at minimum generally 5 days, because most people will resolve and return the baseline by 72 hours. Okay, so let's say we have a different patient who you are also discharging, but on their list of past medical problems or current medical problems also has one of the following, such as chronic heart disease, lung disease, renal, liver disease, malignancy, or alcoholism. So comorbidities that may increase or change the type of pathogens they may be exposed to. In this case, if the patient has comorbidities, then it's either combination therapy with azithromycin and amoxiclav or monotherapy with the quinolones. At our hospital, we've tried to limit fluoroquinolone use just because of the increasing resistance in Enterobacteriaceae, but also the high risk of fluoroquinolones causing C. difficile infection, and now new FDA black box label warnings for things like aortitis, aortic rupture, tendinitis, neuropathies, myopathies, and a significant number of CNS side effects. Fluoroquinolones should be reserved when there's no alternatives. So in a patient with more severe disease who can go on oral therapy, the beta-lactam-lactamase combination with azithromycin is recommended. And the reason why in this scenario we are adding a macrolide is because with the comorbidities, they may have lower reserve if you don't cover the pathogens that may be contributing. And so this azithromycin is added to cover for atypical pathogens, like the mycoplasma that we generally don't test for.
So what dose is your for the most class of the high dose of amoxicillin? Just 1 gram PAD?
Yeah, so in the guidelines, there's 3 different options for dosing of amoxicillin. 1 gram TID will be the dose to cover for more severe community-acquired pneumonia. In patients who are going to be given amoxiclav, generally it's 875/125, so that's a lower dose of amoxicillin component. It's unclear whether that makes a difference in their outcomes, so both doses are recommended. You can either use the 1 gram amoxicillin, or if you're using amoxiclav, the 875 BID, with the possibility of increasing the amoxicillin component by another 500 of amox on its own.
Sorry, Victor, I might have missed this, but what's the reason doxycycline is not used for the amoxicillin?
What is the reason doxycycline is not on this list?
Yeah.
For severe? Because amoxiclav is going to cover the strep pneumo, and then the azithromycin is going to be more towards atypical pathogens. So the azithromycin is broader spectrum therapy than doxycycline for the atypical pathogens, specifically for Legionella.
Well, doxycycline doesn't cover Legionella?
No. So your only 2 antimicrobials that have proven effect against Legionella is azithro and moxifloxacin, or quinolones, so levofloxacin, moxi, and azithro. Okay, what about non-severe CAP without risk factors for MRSA? So we are seeing variability in when anti-MRSA therapy is being given. So we'll tell you that the MRSA risk factors is only if in the past you have a history of MRSA infection in the lungs, so not just colonization. So someone has MRSA skin and soft tissue infection and they present it with pneumonia, that's not necessarily an indication to give vancomycin therapy. I think if you have severe cavitating pneumonia and the person has many risk factors for poor outcomes, then they should be given anti-MRSA therapy. But in general, in those without previous history of Pseudomonas or MRSA in the lungs, they don't need anti-MRSA or Pseudomonas therapy. So these are non-severe CAP patients without risk factors for MRSA and Pseudomonas. We are seeing that ceftriaxone and azithro is the most commonly prescribed regimen in the patients admitted, and that's appropriate. We would dissuade you from prescribing moxifloxacin or levofloxacin as first-line therapy for these cases because of the side effects. One thing to note is the dose of ceftriaxone. It seems to become a pattern now that everyone's getting 2 grams. And in fact, 1 gram of ceftriaxone is adequate dosing for community-acquired pneumonia, unless the person's in septic shock and the volume of distribution changes. So in stewardship, in antimicrobial stewardship, we're often just changing the doses back to 1 gram. Overall, that leads to a 50% decrease in antibiotic exposure.
Sorry, I was just going to ask when you would ever do the 1 versus 2.
Yeah, so other than septic shock or heading to ICU with questions about volume of distribution, the 1 gram is appropriate.
The 1 gram leads to less antibiotic resistance?
Well, overall, 1 gram, if overall a health system is prescribing 2 grams for all indications, you automatically increase the exposure of this antimicrobial by 2-fold. And so the risks of resistance could be higher, but also side effects like C. difficile. It's not proven for sure that higher doses will increase the risk of C. difficile, but if we know that 1 gram is sufficient based on the RCTs, there's no need to double the doses in these cases.
And that's Q12, Q24?
Q24. So the only time we're using the Q12 dosing is for meningitis. Yeah. So lastly, actually 2 more scenarios. Another question that they tried to answer is if patients who are being admitted with severe pneumonia, what is your empiric antibiotic choice? So here we're seeing a variable number of options being given. Just show of hands. So if you're admitting someone who has severe pneumonia, maybe rest rate of over 30, hypotension, septic, presenting with possible septic shock, which antimicrobials are you giving for community-acquired pneumonia? So show of hands for ceftriaxone and azithro. Okay, ceftriaxone and moxie, vancomycin in addition to those or as a replacement, piptazo, okay, and ceftazidime. Okay, so in those with severe CAP, if your empiric therapy is going to target MRSA and Pseudomonas, then the recommended regimen is going to be vancomycin and piptazo with atypical coverage. If you are prescribing piptazo, the most common error we see is the dosing of piptazo isn't anti-pseudomonal. So in the scenario where we want to cover Pseudomonas, is the only time you're adding piptazo, it needs to be at an anti-pseudomonal dose. So that's the high dose, 4.5 grams. We're seeing most commonly 3.375 being prescribed, and it's not really having any anti-pseudomonal effect. And then same with vancomycin. If you are prescribing vancomycin for an MRSA, be sure to load them. In the Spectrum app, there is a nomogram for loading vancomycin that takes into account age and renal function.
Victor?
Yeah.
Sorry if I missed this. When are you considering Pseudomonas?
So anyone with a previous sputum culture positive for Pseudomonas. What we know is, like in the literature, there's a lot of risk factors identified for possible, like, is Pseudomonas likely? Things like structural lung disease or chronic COPD. But we're finding at our hospital, like those risk factors don't necessarily apply. So we're just basing it on positive microbiologic culture. Or if the person's in septic shock and you're just unsure, I would cover for that. Because it can also always be changed. And we're using the the MRSA screening for the NARES to de-escalate patients from vancomycin because it's quite reliable if done within the first 48 hours if MRSA pneumonia is suspected. So even in scenarios where we're not getting lower respiratory tract specimens, the swab of the NARES is helping target our therapy. So just a quick reminder, the ATS guidelines for severe CAP haven't changed. It's septic shock in need of vasopressors or respiratory failure requiring mechanical ventilation. So any one of those major criteria will count. If they don't have these major criteria, any of the 3 minor criteria for severe CAP would count. So that's leukopenia, thrombocytopenia, hypothermia, hypotension, tachypnea over 30 per minute, confusion, and multilobar infiltrates. So these are the criteria that were used in the RCT for more severe CAP. So then the last question, which has come up quite a bit, is corticosteroids for community-acquired pneumonia. I think about several months ago, I think a resident presented a meta-analysis on this. I don't remember what, because I remember corresponding with somebody with regards to corticosteroids. I don't know what the final outcome presented was. So are most of you using prednisone or hydrocortisone for patients with pneumonia? You are? Okay.
Well, I do, but only for people who've got a moderate to high pneumonia severity score.
Okay. So, Dan?
I represented later on a presentation at Whistler, and we look at the Cochrane review suggesting the number needed to treat for severe pneumonia was 18.
Yeah. So this group for the guidelines, IDSA guidelines, reviewed the same literature, and in the Cochrane review, the results were driven largely by one RCT. There have been several RCTs comparing corticosteroids and those with pneumonia. The biggest limitation in those studies is risk stratification. It's unclear in most of the trials what they considered severe versus non-severe pneumonia. And also one of the RCTs that drove the results, driving down the number needed to treat, had a huge effect size that was a lot different than a similarly designed RCT that was published in another study that was in the Cochrane Review. And so this group that looked at the use for corticosteroids had recommended against using corticosteroids unless you have the most severe patients, and those are defined as requiring treatment for septic shock. So similar to the Surviving Sepsis campaign, pneumonia and septic shock would be considered for corticosteroids. So in the majority of patients who are admitting to CTU, the recommendation is not to start adjunctive corticosteroids because it doesn't have a clear enough effect on hard outcomes like mortality at 30 days or 60 days, and increases many of the complications like hyperglycemia and other side effects of the steroid use. So in conclusion, for the steroids, it's recommended only for those with severe pneumonia and septic shock. So we'll update some of the changes on the spectrum map. Majority of the recommendations still stay the same in terms of empiric antibiotic use. One thing to consider is duration of therapy. Many RCTs now have shown that 5 days of therapy is sufficient for community-acquired pneumonia in the majority of cases who don't have MRSA or Pseudomonas. So in hospitalized patients, we are trying to stop therapy at 5 days, especially if the vital signs have returned to normal and the person's having normal oral intake. This is different than what was previously recommended for longer courses of therapy. Most the RCTs comparing short course versus long course have shown 5 days is sufficient. So if you are prescribing, say you have that patient that you're bringing back twice for IV antibiotics, if your decision is to switch them to oral therapy, probably 3 days of additional antibiotics is sufficient versus what we commonly see in the current prescriptions of 7 or 10 more days of antibiotics. Okay, any questions about CAP? No? Okay, thanks.
That was very easy. Okay, thanks again. Okay, so moving right along, we're going to hear from our very own Sarah McAnally. And yeah, you can just talk into that. Okay. Can you hear me, Sarah? Can everyone hear Sarah? Yeah? Okay, great. So, yeah, thanks for having me. I'm going to talk to you today about severe pulmonary illness, NYD. So I'd just like to acknowledge Dr. Rich for supervising me with this, and Dr. HM as well for planting the seed for this idea. So just start with some cases. So number one, a 30-year-old female with 1 month of dyspnea and chest pain presenting to the emergency department. This was her image, a CT that was done. Oxygen saturation was 90%, otherwise her vitals were normal. She did have a chest x-ray done first, which showed a patchy infiltrate in the left lower lobe. A mild leukocytosis. This is the CT that showed bilateral ground glass opacities. And she became increasingly agitated, dyspneic, and hypoxic in the department. She was treated with oxygen, broad-spectrum antibiotics, and eventually was intubated and mechanically ventilated. Number two, 35-year-old male with dyspnea, fevers, cough, chest pain for 3 weeks. Heart rate a little bit up, oxygen saturation 93, and a temp of 37.9. Chest x-ray also bilateral infiltrates to the bases. White blood cell count of 18, a lactate of 2.3, otherwise normal. And CT showed extensive ground glass nodules, also became increasingly dyspneic in the department. Was treated with oxygen, broad-spectrum antibiotics, and also oral steroids in this case. Third one, 50-year-old female with COPD, increasing productive cough, dyspnea, weight loss for 2 weeks. Heart rate 95, blood pressure a little bit up, a little bit tachypnic, and 87% for her oxygen saturation.
She had a chest x-ray done, which showed bilateral diffuse infiltrates, was treated with oxygen, salbutamol, and atrovent NEPs, methylprednisolone, broad-spectrum antibiotics, first BiPAP, and then was intubated and mechanically ventilated. And these are all real cases from case series that have been put out with their real images. So what do they all have in common? Vaping. So I'd just like to talk a little bit about the details kind of around vaping. So the definition of vaping is to inhale vapor from a battery-operated electronic device or e-cigarette that heats up and aerosolizes a liquid or solid. These are the range of devices that can be out there, like a snapshot of a few. So the original kind of e-cigarette was developed by a Chinese pharmacist back in 2003. They came to the Canadian market in 2004. And then there's been a huge explosion in the kind of diversity and the range of devices. The purple device in the center is a kind of classic vape pen. This one has refillable cartridges. You can make your own e-liquids. You can tamper with the devices. This is the one, actually Dr. Mark Tyndall, who is a local infectious disease and addiction specialist, just wrote an article in the Globe and Mail last week talking about this being kind of the area of kind of grave concern right now with these devices that are very, they're interchangeable, you can tamper with them, you can make your own e-liquids and put them in these sort of devices. And then over on the far right, you have the Juul device, which I'm sure everyone has heard about at this point in time. Dominates the market. It's about 50% of the market of e-cigarettes. These are non-refillable cartridges or pods. Important to know about the Juul device, it's only nicotine products, so there's always nicotine in them. And again, this has been kind of really popular in the media for many reasons. So this was very confusing to me initially when I started to look at this, to what exactly we were talking about in terms of the substances involved in vaping. So just to start, the kind of e-liquid that you hear about, there's quite a bit of variability in this. And again, people make these at home. There's recipes out there on the internet. But classically, there's either a combination or individual use of propylene glycol and vegetable glycerin that's used to produce these e-liquids. The purpose of them is really to kind of produce the vapor that's involved with vaping. And this may or may not involve flavoring. So with the flavoring, again, there's huge variability in this. This, again, from that article from Dr. Mark Tyndall talking about the concerns around this specifically, is that these are often found on the black market, they're often bootlegged, and we don't know a lot about what's going into these often. There's some that are a little bit more regulated, but certainly, like such as the Juul device, certainly not FDA regulated, but they are a little bit more regulated, but there's a lot of concerns around the variability with this. They can contain trace metal elements, and also early kind of on, and a few years ago, there was a lot of concerns with the e-liquids containing diacetyl, which was made more popular in the 90s. People probably have heard about it with popcorn lung. A lot of youth are actually very familiar with this around vaping. And there was a series of about 8 patients who were popcorn factory workers who were developing this really severe lung disease, and they found that it was actually related to the diacetyl. That's a food additive that gives like a buttery flavor that was found to be causing the lung illness. So this was actually found to be in some of the flavoring products for actually like popcorn flavored e-liquids, but it's been since removed largely, but it still exists in some of the liquids out there. May or may not contain vitamin E. There was a series of about 5 patients in New York who were found to all have vitamin E in their e-liquids. So that was made popular for a little bit of time there, suggesting that this might be the cause of VAPI or this VIPI, this lung-related illness related to vaping. And so that's possible. And then there's also the nicotine that, may or may not be in vaping devices. Some people vape without nicotine, and if they're using benzoic acid, it means that they're using the really concentrated nicotine salts, which is primarily used by Juul. And the purpose of it is really to lower the pH vapor and to give it a bit of a better mouthfeel or better enjoyable experience. That's their reasoning behind it. And then lastly, may or may not contain cannabinoids. So THC, CBD, hash oil, or dry vaping. So people may just use dry marijuana with none of the rest of the stuff. So there's really huge variability in what people are vaping. The two kind of most popular ideas out there right now are still around the e-liquids, that most of them are oils, and the THC oil.
What happened? All of a sudden, I feel like I know better than everyone else.
That's because anytime someone walks through a cloud of vape smoke, a millennial is born.
I think I feel it.
So just want to talk a little bit about who is vaping. So we know that the numbers generally of people vaping are like skyrocketing. This is for adults from the BDC. 2011, 6 to 7 million to 42 million at this point, adults. But what's most concerning is the prevalence of adolescents that's increased. So this is from the New England Journal of Medicine from the middle of September, looking at adolescents who have ever vaped in 12th, 10th, and 8th grade in 2017 to 2019. Gone from 12th grade 25 to 40%, 21 to 36%, and 10 to 20% in 8th graders. Also looking at numbers of daily vapers in the same age groups, almost 12%, 7%, and 2%. So this is where kind of most of the concern with vaping exists. This is in an era where smoking rates, both in adults and adolescents, has plummeted. This is data from March of this year, up to 2017. But then 2017 to 2018, in the same article, has actually seen an increase in smoking of cigarettes specifically. So there's this whole idea that vaping is almost normalizing nicotine usage in some ways, or it's almost providing like a gateway back to cigarettes. So this is the other concerning feature. Why is this happening? This is what youth are being kind of bombarded with in the media. It's being popularized as a healthy alternative, which, as Dr. Mark Tyndall said in his recent article, it's possible for people who are smoking with highly regulated products. It actually is a better option, but for a lot of youth, any smoking or vaping is not a good idea, and it's largely around the unregulated and unknown substances. Also, this is just from, I saw this back to school sale. This is a vaping shop. So it's really targeting kids. I mean, you can just see how youth would be, this would be very appealing. It's colorful. It's colors such as, or flavors such as sour key, chocolate milk, fruit, and candy. This is in terms of the flavoring. So you can see why this seems benign in many ways. So the CDC investigation is going on right now. They still at this point are not saying that there's any single substance or product that's common to all cases, but we know there's over 1,000 cases now in the States, largely of which are male and under 35, and there's been 18 deaths, and this was current as of October the 1st. I've never done a presentation where I've had to check the CDC before I've walked up just to make sure there's new evidence out there. So this is what the latest has been. And the chart's just showing, that's from July 25th of 2019 to September 19th, showing the dramatic increase in cases, which is for a variety of reasons, but this is what's been documented. In Canada, we still just have the 2 cases, the one suspected case in London. This was the first case that actually was popular or was put out in the media, and it was the 20-year-old that was known to be daily vaping. And the only issue identified in that case was that he was vaping cigarettes, e-cigarettes. And then there's the first official case in Montreal that was a 50-year-old man who was daily vaping, and it was a nicotine-only product in that scenario. The first case just isn't confirmed yet. So what exactly is happening in the lungs? This is the big question, and I'm not going to answer that here today, but I'll tell you what I've read about and what's out there right now. So likely they're thinking it's a chemical or a toxin exposure. Don't know what it is yet. There's a lot of, again, theories around this, but there's no one that's ready to say it's this, or no one that knows exactly what it is specifically that's causing it. There's also the theory that the actual process of aerosolizing and vaping from the exposure of the high heat on the heating coils in the devices is actually potentiating or releasing new compounds. Specifically, there's concerns around the metal from the process. There was a few cases that presented like metal fume fever, which is a pulmonary illness often seen in welders that presents with a flu-like illness with pulmonary infiltrates. So there is a kind of a theory around this that it might be contributing in some way. But what we know is that there's a range of heterogeneous processes that are being seen, many of which are a pneumonitis picture, chemical or hypersensitivity. There's been a few cases of acute eosinophilic pneumonia, and then a few of the very severe cases of more like an ARDS-like picture. There's also a question around the, again, the process of aerosolizing and vaping, potentiating really small particle size to be able to be seeded in the smallest airways. So we know that we have this very intricate system of defending our airways, and we know that in smokers this is compromised. We know that with cigarette smoking and combustion of particles, they make it down to kind of the tracheobronchial level into the 3 to 6 micrometer size. But we know from previous data that with vaping and aerosolizing, you can get particles much smaller than 2.5 micrometers. So there's a question of whether, regardless of what the toxin chemical substance is, it's just the fact that it's getting into those smallest, most pristine airways that may actually be causing these illnesses. This is a neat article that was just put out at the beginning of October in the New England Journal of Medicine by Butt and others, showing biopsies done on 17 patients with this kind of vaping-related lung illness. And what they kind of concluded from their look at the biopsies is that it's likely not this lipoid pneumonia that was kind of, it's been very kind of popular in the theories of what's causing it. They think that likely there has been cases of lipoid pneumonia, but they think that's likely a marker of exposure to the oils being in the lungs versus actually the cause of the lung toxicity. So that's what they kind of deduced from their 17 case patients. Also, it's likely not related to any infectious disease, although that floats around as a theory as well. And then it's also not likely the bronchiolitis obliterans of the popcorn lung, which is also a very early theory. That goes back to the diacetyl I spoke about. And that's seen primarily in lung transplant patients. So often in about 50% of lung transplant patients, they have failure of the transplant due to this process of scarring of the bronchioles. This is diagnosed usually on CT biopsy and PFTs, and they're just not finding consistent findings clinically with the cases that they're seeing. So this is kind of where we're at in terms of theories. Dr. Bonnie Henry, the Provincial Health Officer in BC, put out some guidance in mid-September for us in the emergency department and all physicians. It's largely around Ministry of Health reporting. They've asked us to look for case patients who reported vaping 90 days before symptom onset, who also have pulmonary infiltrates on X-ray, and who also have no other attributable cause of disease. The CDC also provides some guidance around history taking and kind of increasing our suspicion when we're seeing patients. This data comes from a neat paper put out by Leighton in the New England Journal of Medicine as well in early September, looking at 53 case patients. These were both suspected and confirmed cases of vaping-related illness, and 98% of them presented with pulmonary symptoms, obviously, but also 82 with GI symptoms and 100% with constitutional. So it's just kind of making us look at these symptoms a little bit more, and if you're seeing people with those, just to have a little bit more of a trigger as well. They're also asking us to get really detailed information around substance and source, the device that's being used, and then any other potential cases in order to track. Obviously, they've given us some guidance around management, and oxygen on a hypoxic patient is going to be part of your practice, but also early thoughts around corticosteroids, oral or IV. So in that same study of the 53 patients, 92% received corticosteroids, 62% of which were IV, and they were all treated for at least 7 days, and there was 1 death in that 53 group of patients. They also just asked us to think about anticipating rapid progression of the disease and early intubation, and then not so much in the emergency department, just in terms of considering who to refer to and talk to about these patients. Early on is bronchial alveolar lavage. That's more for the kind of lipoid pneumonia, and also just lung biopsies. And then they said it's also important to think about monitoring of pulmonary function, even if these patients are going home from the emergency department, to think about monitoring them in the community in the future. So just to wrap up, our cases that we talked about, the first case went on to have a lung biopsy and showed an organizing pneumonia. They were treated with IV steroids and they fully recovered. The second recovered actually just with cessation of vaping. They also received broad-spectrum antibiotics in the department and oral steroids, and they were found to have a pneumonitis. And the case 3 was a COPD with everything that they got in the department, and they went on to receive IV steroids, but unfortunately passed away in the ICU on day 2. So I will just leave you with that.
You're smoking the vape pen?
No, I'm smoking a real cigarette like mothers are supposed to do.
You're such a hypocrite. At least vaping is healthy.
Oh, don't be an idiot. Vaping is just as bad, and you look like a douchebag.
No, I don't. I look cool.
Go ahead. Hold it to your mouth.
Oh my God, I'm a douchebag.
Okay, thank you. Yes. Yeah, they were part of the Leiden series. Yep.
You mentioned 80-something% had GI. Mm-hmm. What are the GI specifics? And is that in addition to their pulmonary symptoms or in isolation?
Yeah, so again, that's the Leiden case series of 53. It was nausea, vomiting, diarrhea were the GI symptoms. Can people hear me? Yeah. And what I can tell you is of those people, 82% had GI, but like 98% of them had pulmonary. So yeah, 2% maybe didn't meet that criteria. Yeah. Yeah.
Thanks so much for an informative and timely presentation on this. Have you come across any kind of head-to-head comparisons of the incidence and prevalence of lung disease in, say, cigarette smokers versus vapers? I guess I'm more curious about the actual, safety of that compared to cigarette smokers.
Yeah, that's a good question. No, so that Dr. Mark Tyndall put out that article last week, kind of emphasizing that point. Is that there's this huge outcry over vaping right now, and there's many concerns related to it. But his argument was likely in adult smokers who are already exposing their lungs to combustion, have that damage already. Vaping, a more regulated and controlled product, is likely safer. So he was saying as well in his article, there's not a lot of evidence. There's no evidence out there at this point. But we shouldn't completely be just saying no vaping at all. Although at this point in time, kind of around there's a lot of confusion around it and there's a lot of unknowns. That is the guidance that is out there, to be telling people not to vape at all. But I think that's the question. Yeah.
How sensitive is plain chest X-ray for this condition?
I will throw it back to you. How sensitive do you think it is? I don't know. I don't know.
They all, in this series, they all have abnormalities in chest X-ray, or did for some of them?
Yes, yeah. Yes, they did. Yeah, most of them had bilateral infiltrates.
So they have a normal chest X-ray, and it's probably not the vaping treatment.
Yes, I think so.
Just repeat that.
That's right. The question was just around the sensitivity of X-ray for identifying these patients, and someone can correct me, but my thought from what I've read about is if they do have a normal chest X-ray, that the likelihood is fairly low.
Sorry, and just for clarity's sake, despite the new fancy term, this is essentially a chemical-induced ARDS, right?
Yeah.
It would present pretty much the same way.
Yeah, and there's a lot of VAPI is the new one I'm hearing too, but the CDC is still just saying severe pulmonary illness, and Health Canada as well. So I think you're right, though. I think what we know is that it's fairly confident that it's like a pneumonitis type picture, and other than that, unknown.
Okay, I'm going to cut you off.
Yeah.
Thank you so much, Sarah. That was awesome. And we're just going to go on to our last speaker today. It's Christy Sutherland.
because I want to finish on time, because I can't see Dan tapping his foot, but I know he is. And thank you so much for coming.
Yeah, totally. I'll just right up. Okay, 10 minutes. We're going to whip through it. This is a mic here? Okay. All right, you guys may recognize my name because you probably see my patients all the time. They probably come in, yell at you, steal a sandwich, and then go. So I'm the medical director of the Portland Hotel Society. I work in the downtown east side, and I trained here at St. Paul, so you may remember me from when I was a resident. So trauma-informed care came out of this ASA study, the Adverse Childhood Experiences Study. This was done in California, and it was actually in an obesity clinic where a physician, over time, as he was following people with terrible obesity and talking to them over the years, they started telling him about trauma in their life, of mostly sexual abuse in childhood. And he thought, this seems more than what should be happening for baseline sexual childhood abuse in the world, I hope. And so he developed this tool. And it turned out that most of his patients have been traumatized with these adverse childhood experiences. You can look at the tool, you can use it in your office. If you work in community, it asks about neglect, witnessing violence, experiencing violence, sexual abuse, like food insecurity, feeling unsafe as a child. And we know that the more adverse childhood experiences you have, the lower your life expectancy. So, and that is a dose-response curve. So it is a really powerful epidemiological signal that trauma in childhood lowers your life expectancy.
Patient Jacqueline Longston, please return to Providence 9 Alpha.
What are the chances? And it's interesting because it increases your risk of having things that seem to have nothing to do with trauma. So substance use disorder, okay, it makes sense. You've had a lot of trauma in your life, probably you're going to use a little bit of heroin. But like, what are the chances your diabetes is going to be worse? Or your dementia is going to be worse? Or that your all-cause, your cardiac stuff is going to be worse? So for my patients, I just assume that they've all had trauma when they walk in the door, and I think about that as I plan my clinic and I plan my day. And I can tell you, it's made my life easier. I'm coming around to 10 years in the downtown east side, loving my job, I love my work, I enjoy seeing my patients, and it's because I think about trauma when I take care of them, and so I don't get annoyed at them for acting the way they do, because I know the way that they're acting comes from their trauma. And these are lasting impacts throughout someone's life. And so the key to trauma-informed care is don't ask in your head, what are you doing? Because it is so tempting, where I have patients where just the most horrific wounds, I have the sweetest nurses, the Blue Planet plays continuously in my waiting room, I have like diffusers to have lavender scent throughout when I have flowers, like I just have the sweetest secretaries, the sweetest nurses, the nicest doctors. And if you come to my clinic and you have horrible, painful wounds, and I'm trying to give you some sufentanil to have the nurse dress your wounds, and you call us cunts and throw a chair and leave, it is so tempting to say, what are you doing? Just like sit there, take this sufentanil, let me take care of your wounds. That's the wrong question. If that's what you're asking in your head, you are in for trouble because you're going to get annoyed at your patients and leave work feeling unwell, mentally. The question is to think, oh my goodness, what happened to you? Like, what has happened in your life that you can't come to my office and say your name at the front desk, sit down and have a nurse tend to your wounds, and then see me like this nice, I'm trying to be as nice as I can and give you as many opioids to inject as I possibly can. Like, if you can't get through that process of having it be so low barrier and so kind and so thoughtful along the way, my goodness, you have had a rough life. And so that's what I think all the time. When I see my patients and, you know, they're throwing an IV pole at me at CTCT, or they would take I guess I remember the Bosman Hotel, one of my favorite jobs I've had, where they would take a 2x4 and they put nails in it and they would swing it down the hallway. I'd say I once tried to do a home visit on someone, and he wouldn't let me open the door. He just said, "You just renew my meds, you power tripping cunt." Like, my gosh, what kind of life have you had if that's how you react to a doctor trying to come to your house to renew your medication? Like, your life has been rough. And so that's really the flip inside your head that you have to have when your patients are being turkeys. That's what we say. I'm like, you're being an absolute turkey. I'll tell it to my patient. I'll be, stop being a turkey, scoot. Like, I'm not a cunt. Come back tomorrow. We'll try again, and I'm going to fax your methadone script to your pharmacy because I want you to be safe because I care about you. And so this all is sort of nestled within this thing called the risk environment framework. And this is what I spend a lot of time thinking about in the downtown east side. So this envisions drug harms as a product of the social situations and the environments in which individuals participate. It shifts the responsibility for drug harm and the focus of harm-reducing actions from the individuals alone to include the social and political institutions that have a role in harm production. So this is an uncomfortable way to view the world because it doesn't let us off the hook. So what it does is it says, like, for so many people, we put the burden of safety on them. Like, oh my gosh, you can't believe you had another heart attack, you should exercise more, you should eat healthier. Oh shoot, you're living in poverty and there's no sidewalks where you live and you aren't safe to go out. that you have to shift from looking at that patient in front of you to turning around and looking at the world that we've created, that we're all living in, and say, like, how is this patient negotiating their life, and why are they here right now in front of me with this, like, suffering? So I can think of two examples that I see a lot in my clinic. I was trying to think of emerge examples, but it'll be interesting if you guys think about it and email me afterwards with some ER examples. We know that women who inject drugs are at increased risk of seroconverting to HIV and hepatitis C. And this is well documented in the VITA study. So here in Vancouver, our wonderful, massive cohort of IV drug users is one of the best sort of data sets in the world of looking at IV drug use. Why would women be at increased risk of HIV if they're an IV drug user? There are so many clean needles all over the downtown side. I give out boxes of 1,000 at a time. You can come in anywhere. You stumble over clean needles everywhere. So if you were not a very thoughtful person and you had a woman come into your clinic and have had seroconvert to HIV, and I've had this happen, you might be tempted to think, why aren't you choosing to use clean needles? Because there are clean needles everywhere. You've missed the point. You have to not look at her, and you have to look at the world she's living in. So women often exchange sex for money or sex for drugs, and they have a pimp or a boyfriend, and they have to report back to them every 8 hours, because that's how long heroin lasts. The pimp will inject her with heroin, then she has to go out and do sex work and have a certain amount of money she has to bring back in order to get the next injection from him. Women are often second to the needle. So what that means is they come back to their pimp or their boyfriend, and he cooks up inside the syringe. They do what's called a shake and bake, where they put the drugs and then they put the puddle water, or hopefully some sterile water, in the syringe, shake it up, and take a lighter and cook it inside the syringe. He then injects himself, and then he'll inject her. And the way that pimps often inject women is through the jugular, because that's the easiest place to hit. So she has to lie down, tilt her neck. Sometimes they shine their little iPhone light down or a mirror, and then he injects her. She can't in that moment say, like, oh, can you change the needle? She's worried he will kill her, or he will choke her, or he will not give her drugs. She doesn't even know if he switched the needle. Maybe he's not even giving her drugs at all. She's making the less risky choice in that moment to accept that needle, truly. Like, she's avoiding her own death or avoiding excruciating withdrawal. And that puts her at increased risk of HIV. And then so she seroconverts, and it's an extra kick in the teeth to come to a clinician who's not caring and saying, why didn't you choose to use clean needles? There's clean needles everywhere. You missed the boat, right? So you want to ask, like, who injects you? Do you know how to inject yourself? Do you want to sit down with one of my sweet nurses and learn how to inject? Where are you getting your drugs? Maybe you need to be on my injectable program. Maybe you need to go to the women's only injection facility. There are so many ways that we can change her environment to provide her with safety that don't rely on her trying to negotiate, trying not to die. So same with women who present with recurrent chlamydia, that I have patients who get gonorrhea over and over and over. And if I was not very nice, I'd say, why don't you choose to use condoms? There are condoms everywhere. We give them out all over the place. Wrong question. The question is, are you safe to ask to use condoms? Because for many women, regardless in the downtown east side or wherever they are, their partners don't want to use condoms, or their partners will take off a condom midway through sex. So she doesn't even know that she's not using condoms. Or if she's exchanging sex for money or sex for drugs, I want to say, like, are you doing it online? Is it John's that you already know? Are you at the car window and you're negotiating outside the car? You have 20 seconds before the cops are coming to arrest. You have to get in the car or not and decide, is that guy going to murder me or not? I don't know if you guys have seen that, like, red light flyer every week. I always put it in my office where it'd have, like, a photo and a description of the man and what he did to her. And it's like a memo to all the sex workers saying, like, watch out for this guy. He tried to choke me and run me over. And they took a condom off midway through, and then, you know, it's just horrific. Like, reading it is upsetting. And so we have to think about that for our patients to say, like, how did you end up here in this situation? Probably it's pretty complicated and horrific. And any time that I feel annoyed at my patients, I just have to take a moment and think, like, okay, Christy, like, what's their blood pressure? What's their lipids? What's their A1C? Do you need to adjust any medications for this person? Like, are they due for their fit test? Like, I just have to take a moment and think to myself, this person's at increased risk of death because of the trauma in their life and how incredibly annoying they are and how they keep trying to threaten to kill me. But it's still my job to take really good care of them, and I still have to just, like, bring myself back to the moment, look at their numbers and be like, okay, your Framingham score is 20%. I'm going to start you on a statin. And so then this is sort of what I feel my job is as a family doctor in community working in a nonprofit, is to create safe environments. So this goes beyond safer use by individuals alone to focus on the determinants of harm, including drug policy, policing, income, and housing. And so that's why as a family doctor I love housing and I love safe indoor space and thinking about, you know, how we can provide safety to people. In my life, I'm so safe. Like, my door locks in my house. I know everyone who lives in my house and not trying to hurt me. I have clean drinking water, and if I go and buy alcohol, I know it's not going to poison me. I mean, those are all luxuries that city bylaws have provided to me, and the privilege of my life has provided to me that my patients don't have. And so it's something that I think about, that if ever I'm tempted to be annoyed at my patients, I don't think, what are you doing? I think, what happened to you? So think about trauma. It will make your life easier. And think about trauma when you're setting up systems. I think about this with my clinic, where as soon as you enter the door, my thoughts are, okay, let's say you've been raped 100 times, and you're coming in here for a pap test. What can I do along the way for each of your interactions to make it more likely that we are successful with that pap test without traumatizing you some more? And think about the risks that your patients are navigating, that they are trying to survive, and they're often making the right choice because of the terrible situation they're in, but it seems like the wrong choice for us medically because it involves not getting their wound care tended to. I thought I would just end, I know I have a minute left, but at the Boston Hotel this one time, someone came down, and Nurse Sarah and I were in the front office, and he said, you know, a guy in 201 is overdosing, and the guy in 201, he was so violent that paramedics and firefighters would only see him if there were police present. But he was sort of on death's door, so Nurse Sarah and I ran up, and his O2 was 30%, and heart rate, I don't know, 40. Like, he was moribund, basically, and he was blue, and his head was inside a tackle box, like all sort of in this disgusting room full of hoarding things, and I had my flip-flops on that day. It was like the one time I wore flip-flops to work. It was the wrong decision. And then so Sarah and I were doing his airway and everything, and I was like, oh, Sarah, like, no one knows we're up here. And so I just like called 911 on speakerphone, and I was like, oh, the nurse, doctor, we're up here doing this. This was like in 2012, so it was before the overdose crisis. It was like a big deal to have an overdose. And then the firefighters arrived and the paramedics arrived, but they wouldn't come in the room until the police came. And so I was like, wait, pass out, guys. I'm like, Nurse Sarah's like a tiny little person. I was like, it's okay, you can come in. So they came in and they said, get out of the way, girls. And they took his sort of limp body out to the hallway and took over the code, and then he came to, and he said, what the fuck happened? And they said, you overdosed. Dr. Sutherland saved your life. And he said, Dr. Sutherland, that bitch couldn't kill me on her best day. And they wheeled him off. And then a week later, he came to see the nurse, and he said, do you think Dr. Sutherland would start me on methadone? And she was like, I bet she'd be thrilled to start you on methadone. And I was like, gosh, yeah, come on in, let's get your urine, tell me about your drug use, let's look at your track marks, do you have any infections? For sure, I'll start you on methadone. I'm going to have the pharmacy call you after you've had 3 doses, we'll go up, this is wonderful. And I think that's sort of an example of trauma-informed care. Like, I'm not mad at that man. Like, and I don't take anything personally. I just see it as like, if he had high blood pressure, I wouldn't be upset at him, and if he calls me a bitch who couldn't kill him on his bed on my best day, I'm also not going to be mad at him, and I still am just going to give the best care I can. So, there. Thank you. Oh, that's good. Okay, see you guys around. You can call me if you receive one of my patients.
So we have a meeting upstairs, guys, for all the practice plan numbers.
Okay. And at the risk of making Dan really mad, I'm not going to give my talk, obviously, but I just wanted to just go through, because I was going to do a number of practice points, and the first one, or the second one actually, was kind of a practice changing thing, and so I just wanted to just ask the group very briefly. I'll take 1 minute to do this. It's about atraumatic needles for LP. So I'll just say very quickly, the atraumatic needles are the left ones, the pencil-shaped needles like the Whitaker, whereas the ones we typically use are those beveled ones. And forever, there's been hypothesis that the atraumatic needles cause less post-dural puncture headache. And only recently there's been better studies. And this really good study came out last year, and it, I think, should be practice changing. It's 110 randomized controlled trials were reviewed. This was out of McMaster, and it showed that on every subgroup it was substantially better. So it decreased the risk from 11% to 4% with no harm. And so that triggered the clinical practice guideline, which suggests that we should, in every situation, be using, for all indications for LP, atraumatic needles to decrease the risk of post-LP headache. And so I think we should be doing that. And we can't actually even get them in our department right now. So what I was going to say after I gave this bit of my talk was that I would like to just get the ball moving on trying to change our LP kits if there's consensus on that. And obviously I haven't been able to give you all the information, but I just wanted to let people know that that's something that I'm interested in doing.
Is it an option with the kits that you can change the type of needle?
I don't know. I've emailed Tanya, but I don't know. Okay. Right now you have to call CSD to get them. Anyway, I just wanted to let people know about that because I don't know if anyone has dissent right now or questions, but Dan's going to kill me. Okay. No dissenters. I'm going ahead.